we go.
Okay, welcome everybody to the evening. Thank you so much for being here. Wanted to welcome our guest, Dr. Bath and Shelli. A lot of you know Shelli. She's been a nurse at NLG for 7 years. She started as a staff nurse at NLG in 2010 and is now nursing coordinator. She focused her nursing career on community nursing, school nursing, and psychiatric nursing. I didn't know that, Shelli. She received her bachelor's in nursing at Salem State and master's with a focus on school nursing at Elms College. Also wanted to add that she has gotten us through COVID at Neshoba Learning Group. I'll never forget the story that you told at an auction about storing all the gloves and the scrubs and all of the masks and face shields in your home, in your basement, in your living room. The dedication is unparalleled. So thank you for that, Shelli. We also have Dr. James Bath. He's a board certified family medicine physician committed to serving patients with autism and other neurological neurodevelopmental disorders. He offers primary care services at the Lurie Center in Lexington, and he'll be there full time in January. Thank goodness. Dr. Bath understands patients with autism and other neurodevelopmental disorders have unique needs. He offers compassion, flexibility, and thorough care for each patient at every visit, focuses on caring for patients of all ages through life's many transitions with a collaborative approach. He coordinates care and communication with multi-specialty teams to help patients and families navigate a complex healthcare system. And I think a lot of us know, have had a little bit of experience doing that. Dr. Bath earned his medical degree from UMass Medical School, completed family medicine internship, residency, and chief residency at Tufts. He provides comprehensive care, including routine checkups, wellness visits, school and program physicals, sick visits, and chronic disease management. Dr. Bath is currently accepting new patients at the Lurie Center in Lexington. And Dr. Bath also has a son with autism. I think a lot of you would probably appreciate that. But with that, I will hand it over to you and Shelli to start the program. Thank you guys for being here.
All right, so I'm going to give Dr. Bath the ability to screen share. So I'm going to make you the host so you can get started on your presentation.
All right, very good.
All right, should be all set to screen share.
Okay. All right, and can everybody see my screen okay? Okay, and so thank you all for having me. That was a wonderful introduction, Una. Thank you. It's a lot to live up to, actually. Now I'm nervous. But what I wanted to talk a little bit about is just one of the more daunting things that you go through with our kids who have autism, which is this whole transition of care. You know, through the early parts of their life, which is also challenging, but they typically have a great pediatric group and team that you develop over the years that really take wonderful care of our kids. But as they get closer to 18, 19, early 20s, then there's a big transition to be made. And that is sort of one of the more daunting things you have to come across, in addition to doing guardianships and Rogers and all of that. So hopefully I can help make this transition a little bit easier. And I just have a couple things to present. And so Una already gave a great bio. I really appreciate it. So I've been practicing family medicine for about 15 years in Somerville and Medford. We really wide breadth of patients, from newborns all the way up to 100-year-old wonderful patients I have. And so it's really given me some good experience across the span. And being in Somerville and Medford has been great because there's a lot of younger patients there, a lot of university students. So I've been able to focus on that population as well. And then after my son was diagnosed when he was 3, he was also a patient at the Lurie Center, and I got to know the wonderful people there over the years. And from that relationship, we felt that there's a real need for family medicine for patients on the spectrum, because there was such a gap. And a lot of pediatricians are wonderful and are knowledgeable about autism and neurodevelopmental disabilities, but not so much as you get to the older ages, as they get to be teens and into adults. And so we thought there was a real need. And if not for the pandemic, things would have gotten rolling a little bit sooner, but I think we're back on track, and I'll be starting up there full time in January, as Una had mentioned. So the transition, and I know that, this is something that you see at NLG quite a bit, as there's a, one of the schools I think is geared toward younger kids, and then transitioning into adults. So you see that transition firsthand. And there's a lot of scary questions about, what does my child need? What's to expect? How are we going to find a new doctor? And, that can be daunting. And so thankfully, there are a lot of wonderful doctors out there, whether they're family medicine or internal medicine or what have you, who will take, great care of our kids as they get older. But what we're trying to do with the Lurie Center is try to make sure that it's tailored to sort of the special needs that, both the patients and the families and the residential programs and day programs have that are a bit unique. And so we want to introduce things like doing blood draws and vaccines and other tests that are sort of catered to that, so that it's as comfortable as possible. So just briefly, for primary care, just like as your pediatrician did for your child, it's really management. It is a lot of it's preventative care, it's coordination of care, and it's making sure things don't fall through the cracks. That is sort of the mainstay of primary care, in addition to managing all of the acute lumps and bumps that come along the way. And so the foundation of it is doing annual exams, really checking over, making sure that vaccines are up to date. If there's any blood work that needs to be done to check for blood sugars, for diabetes screens, cholesterol, liver tests, kidney tests, things along those lines. Very important to make sure that's done on a relatively routine basis, not necessarily every year, but just make sure it's being paid attention to. Fortunately, the adolescent age and the young adult age doesn't have a lot of cancer screening, as cancer is just not that prevalent, thankfully. But if there are any risks, those can certainly be tracked along the way. And again, as primary care doctor, it's really the foundation of my job is to make sure I track that for each and every person coming through the office. One of the things that I really try to focus on as well is just also doing all of this with a lot of flexibility, based on every patient that comes through. Some kiddos they don't like needles. They don't tolerate me touching their ears. They don't want to sit for the exam. They don't want to come into the office for the exam. So I've done a couple physicals in people's cars, which is fine too, that works. And so basically doing whatever it takes just to give them the care that they need while trying to make it as comfortable as possible. It's, medical visits shouldn't be torture, for all of our patients. It should be something that, we do as best we can and not make it too onerous for everybody involved. And I try to do that really working closely with, the parents, the staff at the Lurie Center, all of the care managers at the residential homes or at schools. So it does take a lot of coordination in the background, but if we can make it comfortable, it's always really a great visit. And so, so that's really the part I wanted to stress, that it's not just cookie cutter for everyone who walks into the office. It's, we'll tailor it based on what the given needs are. And so this is sort of the composition of the role. The office visits can be like I said, the physicals, but also sick visits. If someone has a cough or abdominal pain, or they're limping, or something's going on and it's just not right, then I really love to see them in the office, check them out, make sure I can do some hands-on, get vitals, that type of thing, do some tests if needed. But telemedicine visits are also available, because I realize that it's not always easy, to get everybody in the office. And so we'll do the best we can there. And then there's all of the administrative side as well. The coordinating care as far as all of the forms, which I know as parents, you guys are all very, very well familiar with, as far as everything that needs to be done, as far as crossing all the T's, dotting all the I's. And so I really try to be as big a help as I possibly can as far as filling all that stuff out, making sure that everybody has what they need. whether it's for a group home or a residential program, a day program, school, work, what have you. And in addition to coordinating care, it's not just the preventative care, but I also like to work really closely, whether it's the neurologist or the gastroenterologist, the psychologist. It's really my role in primary care to help coordinate all that for you as well. You shouldn't always feel like you have to navigate those seas by yourself, because it can be pretty daunting and it can be hard to get a hold of people. So I really see part of my job is to help you coordinate all of that and identify, if there's a need and how we meet that with resources. Like, we're fortunate to be sitting right next to Spalding Spalding Rehab. And I had a patient in the other day who just got a brand new tablet and they wanted to try Proloquo to go, but they didn't know how to use it. So I was able to set them up with a speech and language appointment next door, and they're going to teach them how to use their tablet and get started with it. So, I try to do as much of that as I can as well. And then there's all of the other sort of more basic stuff. And so that's sort of how I see my role and hopefully how I can help. So I will stop sharing there.
Okay, Dr. Beth, do you want to make me the host and go up to the 3 little dots there?
Yep.
And then I do believe some parents sent in some questions, so we can go over the ones that we already have, that we received from Una. And then if you guys have questions along the way, please drop them in the chat and we'll go through them at the end as well. And then Dr. Beth, if you wanted to add anything else.
Sure. So forgive me, how do I make you the host again?
There's
Sorry.
if you go up to my little video where you can see my face, and then there's 3 little dots in the corner, click on that, and then I believe you can make host. Yep.
You are now, tag, you're it.
There you go. Okay. So there's no questions in the chat currently, so we can go through the ones that we received previously that Una had sent along.
Sure. You maybe just to get this out of the way, Shelli, I know there were a couple questions on there about COVID protocols and such. Do you want to address that first?
Yeah, sure. So there was a question about vaccinated and non-vaccinated students. I'm going to go over kind of the rates of vaccination per site, just so that everybody's kind of on the same page at where we're at with that. Our plans for 5 to 11-year-olds, and then kind of also briefly overview what we're doing with mixing vaccinated and non-vaccinated students at this time. Even though we're trying to take it really slow, we have been able to do a little bit with that. So currently adult services, we have a 91% vaccination rate in staff and a 92% vaccination rate in members. At 170 Day School, we have a 90% vaccination rate in staff and a 76% vaccination rate in students. And then at 10 Oak, staff is 89% vaccinated and students are 51% vaccinated. I know that 51% is like, oh my God, why is 10 Oak so much lower? It's because we have a lot younger kids. So we're hoping that with the 5 to 11-year-old booster clinics that we're setting up, we're going to get a lot of those kids in there and get our numbers up a little bit more. But with that being said, everyone's been doing a great job, kind of being very patient with all the changes, reaching out for any questions regarding the boosters. November, I think 23rd is the one for the 5 to 11-year-olds we're going to be offering. We are still offering original boosters and for those who are already vaccinated, and then COVID vaccines for people who are still kind of thinking about it and may want to change their mind, or if not, that's absolutely fine as well. But we're going to continue to offer it throughout the winter. So it's not necessarily something that we're, going to stop anytime soon. So if you want to take your time and think about it more, just shoot me an email and we'll figure a plan out. In regards to mixing vaccinated and non-vaccinated students and members, we do our best not to mix them in like a group setting, such as, a middlehood student or right-sided student spending time in the gym closely without masks on. We're definitely not doing that. We're looking at the space we're looking at the hood where the student is coming from, whether they can tolerate mask wearing and whether they can tolerate social distancing from each other. So right now, for example, the gym is open to all vaccinated students at any time. Non-vaccinated students are more than welcome to also go into the gym at any time, as long as they're able to wear masks, socially distance, and kind of stay within that 15-minute requirement, just so we can make sure that if something were to happen, we were to have an exposure, we're not going to wipe out our whole building. Non-vaccinated students who are unable to wear masks, so the super little guys that we're still working on, we try to keep them in their hoods and give them separate times throughout the building to focus on movement, to do their exercise routines, to get into their groups, and we're trying to keep those kiddos per hood as most we can. We are going pretty much scenario by scenario, so if it's a programming need, like exercising or working on PT stuff or group activities and voc, we are definitely looking at the groups and spacing out the desks in there and getting more kids together to make sure that everybody's getting more in-person services versus the Zooms throughout the building, because we know that's not ideal long-term, and it's been going on for quite some time already. So hopefully that answers everybody's questions about the vaccinated and non-vaccinated. If you have anything more to add, feel free to just send it over and I'll be able to see it in the chat.
All right, thanks, Shelli. So we want to thank too, we got a lot of great questions from parents over the course of the week that I want to just sort of run through. And certainly if anybody wants to expand on any of them, feel free to stop me and I'm happy to ask questions. But one of the first questions was a great question. And it's one we all struggle with as parents and providers. But, having a child who, isn't as verbal and it's hard, they can't really relate when they're having pain, or they seem to have a high pain threshold. So it's difficult to tell, when there's something, truly going on because you can't get that straightforward answer. And so just know that you're not alone in that. That is even a challenge for providers as well. But a couple of suggestions on that one is it's really good to get into the habit of using the pain scale, which I know sounds a little hokey. It's been around for a long time, and it's that thing with the happy smiley faces leading all the way down to the frowny face and the tears. But if you can use that, especially in a situation where something happened, and say their hand hurt or their foot hurts, you can get them into that practice of being able to identify sort of how they feel so that it can be used a little bit more reliably down the road. It takes time, it takes practice. There's some uncertainty with it still, but it's just a tool that's actually been shown to work pretty well, because a lot of kiddos with ASD and adults with ASD, they're visual learners, and they take visual cues much better than verbal cues or written cues. And so this is sort of one of the best visual tools that we have, visual tools that we have. The other thing that we often will ask parents about or caregivers about is sort of abrupt change in behaviors, as I know you have all seen, where all of a sudden your child is more irritable or agitated or not sleeping, or there's mood changes. Those, for providers, that tells us that there may be something wrong. Is it abdominal pain? Is it headache? Is it, do they just feel lousy because they have a cold, like we all do? That type of thing. So that's usually the first thing that you'll see is, some sort of behavioral change or disruption in routine. And then, our job as the doctors really just start to ask the pointed questions. Have they been pooping regularly? Or have you noticed a fever? If not, do you have a thermometer at home you could take a temperature? Do they give any indication of a location of pain? Those type of things. And sometimes it's still a little bit of a search, to try to figure out what's going on. But those are some strategies to start. And then, oftentimes I'll want to have, the patient come in to see me, because you can just do a lot more in person. And you can try to get a sense of how they're feeling or what might be bothering them. So, that's what the sick visits are all about. So that's sort of just a preliminary on, how do you, deal with those symptoms, which, they can't necessarily verbalize. Another one, which is a really good question, which I was just addressing today with a patient, is sort of the weight gain that can come with, kiddos as they get to be, in their teen years, and they have a little bit more flexibility with how much they eat, which isn't always great. And we're always having to fight that as parents as well, especially if they become a little more sedentary and not as active. And so that is a big challenge and in primary care. And so the most important thing is to realize is that, it is a risk, it presents a lot of health risks if, our children start to get overweight, or, our adult kids are getting overweight and not exercising. And so you have to be the champion of their nutrition and lead by example, and, with healthy food in the house, and, constantly trying to introduce as healthy foods as you can. Not easy. A lot of kids on the spectrum, and a lot of kids in general, and adults in general, like what they like, and it's hard to turn that ship around sometimes. But you have to be their champion, and saying no is okay. Even if they're in a grumpy mood, or, being agitated, try not to use food as a reward. That is a mainstay, is that you try to use other positive reinforcement besides food, because it's really hard to get out of that rut once you're in it. We have some great nutritionists that can also help if there's questions about, what could potentially be better food choices that the patient might like versus, what they fall back on, which we know isn't that healthy. And so I really encourage people who are struggling, families that are struggling, to use that resource as well. Some nutritionists are just wonderful at help planning out meals, which don't seem like such a big change for the person who's having to make those changes. If it gets more severe, there's some great programs, weight management programs. One is called the OWL program at Children's for younger kids. And then Mass General has a weight management program, which is sort of a multidisciplinary group that includes everything from nutritionists to, fitness instructors in terms of how to get someone more active, things along those lines. So that's a little bit more of a later step, but it's something that is available to every patient. So I just wanted to let you guys know about that. And again, if anybody wants to stop me along the way, feel free. Good question about sort of coordination of care, especially because, a lot of our kids see, and adult patients see, multiple providers, and how to go ahead and coordinate care. And again, I think that's sort of one of my roles in primary care, is to help you do that. But as far as like with NLG and say the Lurie Center, is Shelli and I have sort of made a real effort to open up communication between us, so that if I get a message from someone, from a parent, I can immediately sort of flip that over to Shelli and say, what's going on there? Is there anything I need to know about? And just keep that communication open, so that, we're all in the loop. There's not a specific vehicle that we can use at this point that would allow us to sort of be on the same like email chat together, because some of it is HIPAA controlled, and we do want to keep, the patient's information secure. So we can't do everything over email, but it is our priority to make sure that we do keep those communications lines as open as possible. So I just wanted to let you know that. And when it comes to, someone asked a really good question about research. And there's a research for those interested in, any research that might be going on at the Lurie Center. There's actually a research coordinator, and I was going to plan on, after the session, getting that information to Shelli and to Liz, so that they have that. And, anybody who's interested can contact them directly as well. I'm going to stop there briefly, just to see if there's any questions. I don't want to talk too much here.
I had one question about if NLG could use or introduce the pain chart with students or members as part of their work. We definitely actually have them, more primarily in the day school, but I do think that we could use them more at adult services as well, especially for those members who are working on already almost there as far as identifying their pain. So I think it's really good to keep going. I will also take this to the clinical directors as well, and send out versions of the pain scale so that they can take them into the classrooms, into the group rooms, as far as the clinical leaders go, and work with the students at the desks on these things, because I do notice that when they come to the nursing office and we bring it out, they're not familiar with it. So I do think bringing it to the desk would be a great way to start as well. So great question. I love that. We definitely already have the resources to do it, so we'll just expand on it.
And this is just an open question for everybody who's on. Has anybody run into situations recently where, you know, they've just sort of felt a little bit lost in the system, like the healthcare system, as far as, you know, trying to get the primary care resources or specialist resources for, you know, for their family member? You know, is that something that you guys, I'm sure you experience it. I'm just sort of wondering in sort of what form that is.
I do have a comment in the chat.
Yeah.
Would love to have a PCP that understands ASD better, especially as their son gets older, but they live far from the Lurie Center. Son is a patient at Lurie, but it would be difficult to have Dr. Beth as a PCP for everyday primary care issues because of the distance. Is there a way that you can be added to his team at Lurie as a resource, but on his PCP, and then maybe transition as to a PCP as he gets older?
Oh, that's an interesting question. Yeah, the distance thing you're right, can be tough, because if, you know, someone, let's say he gets a sore throat and you really want him seen, it's not easy to travel that distance, you know, to make that happen. I think because your son is a patient at the Lurie Center, you know, one of the things that could happen is that, I'm not sure who his provider is there, but we could definitely sort of put our heads together. If you come across something that sort of seems to be a primary care issue, and, you know, whether it's Dr. Newmeyer, Dr. Tom, or Dr. Curie, whoever, you know, your son sees, you know, I am happy to offer, you know, advice I have, sort of like, you know, sort of curbside, you know, some suggestions. It'd be hard to do anything in a more formal setting, because you don't want to necessarily undermine, or not undermine, that's the wrong word, but to do something sort of out of concert with whoever his primary care doctor would be at the time. But I guess the short answer to the question is, if you feel like there is an issue that's not really being well addressed by his primary care doc, to route that through whoever's provider is at the Lurie Center, to talk to me and see if we can come up with the answer you need. That's sort of the best way I can think about going about doing it. All right. So I'll get back to a couple other questions here. So there was also a question back to the referral thing, and about, you know, with folks who sort of better understand working with children on the spectrum and adults on the spectrum. Is there a better referral process for doctors, you know, to specialists that could, you know, handle all the different challenges? And for this, I really wish I had a great answer, but I don't. It's a challenge for the whole medical system to come up with, you know, to have really good resources on the psychology and psychiatry side of things. And so, but one of my goals at the Lurie Center is to help develop a robust sort of referral system that even goes outside the Lurie Center, knowing that a lot of the specialists there are pretty backed up, and it's really hard to get in with them. I want to be able to find providers in the community who, you know, do well with patients on the spectrum. So that is going to be something I'm going to be working pretty hard on. It's going to take some time. And so, but I do wish there was a better referral process for it. Okay. And, oh, a couple really good resources. And I know as parents of kids on the spectrum and adults on the spectrum, you know, you guys are excellent at advocating for your kid and finding resources. But if you haven't looked on it lately, so first of all, the Autism Speaks website is fantastic. And they just have such a range of topics that you can look at. There's a great one, actually. Someone asked a question about, you know, what can we expect with puberty as our kids, you know, start to go through, you know, those ages, which are challenging no matter who your child is. And there's a really wonderful article on there that was partly authored by Lisa Nowitzki, who's at the Lurie Center as well. just talking about how to address all the different challenges with your child, from the emotional to the hormonal. If it's your daughter going through their menstrual period, dealing with more independence, and how to be able to give them a little bit more independence. And so I actually went back through that. They call it their toolkit for adolescents in the transition. It's a wonderful site, and it has a lot of great information on a number of different topics. And then same with the Lurie Center. Even if your child's not a patient there, the resources on the website in particular are really good. They hold these things called coffee convos, which is these informal conversations where they talk about a range of subjects, that are applicable to all patients and all parents who have kids on the spectrum, and can really be great. And you don't have to be part of the Lurie Center to join in. And they just have they have some great videos and other tools for you to use, whether it's on behavioral issues or transitions. So I really encourage you all to go, particularly onto those two websites, and sort of see what tools they have, because they're really good and easy to read and pretty straightforward. Any other questions so far?
Yeah, there's a couple.
Okay.
What staffing and coverage does the Lurie Center provide to assist you?
That's a great question. Thankfully, there is some. So I'm very fortunate to have a great group of nurses I work with. There's the nurses at the Lurie Center, but I also have a crew of, there's medical nurses based out of my what used to be my Medford office, that are going to do triage as well. And they're wonderful with, everyday things from sore throats to headaches to stomach pain to fevers to, I need this form filled out, So yes, so there's a whole nurse triage system that can help with the day-to-day things and get me messages, particularly when urgent. I'll have a dedicated medical assistant that'll be working with me day to day to help, field phone calls, do blood, working on to do blood draws, vaccines. I'm going to work closely with the child life folks there, in the adult life folks there, Julie O'Brien and Ellen Roth, in the resources that they have to help with community resources. And in addition to having all of the specialists sort of at my back, so to speak. So if something comes up that is really outside the purview of what I do in primary care or my knowledge of autism, I have them there to help. So it's a smaller staff to start, but we're going to hope to grow it over the next couple of years.
Okay, the next one. Love that you have the take-home medical approach. What is it, or the medical home approach? What is the best way to communicate with specialists in a way that allows the PCP to be aware of the communication, such as the Gateway Communication Portal? It allows patients to CC primary care once. Does it allow patients to CC primary care physicians when messaging specialists? And how should parents best keep the PCP up to date and able to chime in with their advice?
Mm-hmm. No, great question. So if it's a situation where the most of the providers are available on the Gateway, there is a way to CC it, and so that it can be routed to me in addition to the specialist who you're asking the question to. And so if all the providers are, like, say at the Lurie Center or within the Mass General, Brigham, MGB system, that does make it a lot easier. Because you can copy or even just to send a quick blurb saying I reached out to the neurologist about some tremor that my son was having, just to let you know, and that way I can follow up directly and I'll see it directly in the chart. For my patients who don't have providers at the Lurie Center, or they still have them at Children's or at the BI or someplace else, one of the first things I do at the initial meeting is to learn as much as I care about the care team and get as much information as possible about who's the who would be their neurologist, gastroenterologist, whoever the specialist is. And I'm going to prioritize making sure that we have phone numbers and emails and as much information as I can get so that I can facilitate communication if a question comes up. I do have access to the Children's portal because there's a lot of patients who come over in the transition from Children's. And I've been meeting with their whole transition group in the last couple weeks to streamline it. And so those communication lines, they're not perfect by any means, because they don't allow for that very sort of closely synchronized messaging between their pediatric gastroenterologist, me, and you. But I'm going to do the best I can to make sure all the information's there, so it's as seamless as we can make it. And I do have access to all of those charts if need be.
Okay, do you want me to keep going?
Yeah, please.
Okay. Know if you needed a minute. Okay.
No,
So thank you so much for this session and your work with the ASD population. What is your recommendation for children with complex issues who are seeing many specialists at Children's? Says their daughter sees about 10 on a regular basis and another 8 on an as-needed basis in regards to transitioning to adult care.
Mm-hmm. Yeah, I'm glad this came up, because that's not an infrequent question. And so over the past 2 weeks, I've had the good fortune of being able to meet, there's 3 adolescent groups that work out of Children's, and I've been able to speak with all of them. And together we're putting together a transition packet that they've already done. Children's, as usual, has already done a wonderful job, trying to coordinate this. And so that, if I get a new patient from them, I get as much information as possible about who their specialists are, how to contact them, what the history is. Then we start doing the transition planning. What specialists are, is there some stability with that it'll be easier to do the transition sooner rather than later. But if there's some issues going on with your child that it's kind of a volatile situation, and that specialist, having that children's specialist input is still really important, we won't do that transition quite as quickly, because we want to wait till things stabilize and then make that transition to an adult provider, an adult neurologist or gastroenterologist or psychiatrist. So we'll make those transition decisions sort of really dependent on where things are at within that particular realm. And so, but it's from day one, it's always the priority to look at, okay, how can we start to do this transition so that it makes sense for you as the family and your child, to try and make it as seamless as possible. Some of the challenges we'll run into, because there's no way to avoid it, is particularly on the psychology, psychiatry, neurology front, there's just not as many providers, adult providers that are as familiar with autism patients, especially with multiple comorbidities. So that is going to be something we work through in the next couple of years to try to hopefully build a larger resource team so that we can make those transitions and not have that stress of being at Children's where they really want to move the older patients out. Hope that answered the question.
All right, next question. Do you anticipate that you'll be filling up your practice pretty quickly? That they know you're accepting new patients. How long do you think that might be an option? They're almost ready to age out from their pediatrician.
Yeah, so it's gonna take a while to fill up. Thankfully, I don't want to fill up too quickly. I want to have spots for everybody who wants one. I know there's a lot of demand, but by going there full time, I'm gonna go from having 12 spots a month, which has been from part-time in the past, to 56 sessions a week. So I'll be looking at over 200 sessions a month to offer. And so it's going to take some time, which again, I think is a good thing, because I want to make sure we have access. And so if your child, the patient isn't ready for like a physical, say, until May or June, it's not going to be a problem. I don't want people to think that if they don't get in an appointment on the book soon, that they'll be out of luck. That's not going to be the case for a while.
That's it for the chat for now.
Okay.
I'll cut it.
All right. And so just a couple more really good questions that came through. There were some questions that had to do, and really good ones, because they're all very pertinent, about how managing behaviors and managing medicines around that, with anxiety, agitation, irritation, things along those lines. And my role in primary care is I can certainly assist with those, and in a couple different ways. One is I often I'll get patients who their psychiatrist has left, or they have moved from another state, or they are sort of new to, say, the NLG program and don't have somebody on that side of things yet. And so I have no issues at all doing bridge prescriptions for any patient, because we never want anyone to go without their medications that have been sort of put together over time. And if there's an issue with a medication, like a side effect, that a lot of these medicines can cause, that is certainly something I can field and help patients and parents through. I don't, at least not at this stage, will I be starting any sort of the stronger medicines, whether it's the like the Abilifys or the Risperidons or the Zyprexes, the Geodons, things on those. Those don't really fall into what I know well. But there are certain anxiety medicines, whether it's buspirone or clonidine or guanfacine, that I do feel comfortable with, and that, we can have those conversations, especially if there's a gap in coverage with the psychologist or psychiatrist. So, and the other thing to remember too is, we don't always want to rely on medicines, and so part of my role is to help hook up with therapists that can do some great CBT, cognitive behavioral therapy, which has been shown to be a great way to help, especially with anxiety and phobias, for really patients of any population. And I'm going to try to put together a network that, feels comfortable working with patients on the spectrum as well. Same thing as applies to the ADD, ADHD medicines, which there's a lot of comorbidity with those with autism. Whether it's the stimulants or the non-stimulants like clonidine, guanfacine, Strattera, which isn't really used very much because it's not very effective. I can sort of help in that regard as well. Have those discussions about, what's the right medicine for the patient. And so I'm always willing to have the discussion. I may not be the one to ultimately do the prescription writing, but I always encourage parents to bring it up and ask the question. And I think that is it as far as the other questions go. All really good. Thank you very much. I appreciate you guys sending those along.
And there's still nothing in the chat, so feel free to, we have about 15 more minutes if anybody has any more questions.
Dr. Beth, this is Justine. I am curious, we've been talking about the transition age, and I'm wondering if there's sort of a minimum age that you would see. Like, would you see, because, we have a pediatrician, my son's 11, he's a patient at the Lurie Center, and I've been thinking about, okay, when does it make sense to transition over to someone who can see him for a long time? So when
right. No, there really isn't a minimum age that I can do. I'm used to seeing children, and the only limitation is they get very young, because we can diagnose as early as 2 and 3 now. Is that I don't think we'll have the ability to do all the routine childhood vaccinations, that large section, the amount that they get prior to the age of 5 and 6. That would be the only limitation. But after the age of 5 and 6, at least from a vaccine standpoint, they really start to spread out, as you know, and they're really, except for flu shots and the occasional booster, that's not nearly as much of a limitation. So sort of once they get past that 6 and 7 year old age, it's fine. So 11 definitely fits into that category, because it's the primary care is not as much sort of vaccination based, and it's different. It's transitioned to adolescent care at that point.
And Shelli, I don't know if you could answer a question I had about obviously COVID protocol in terms of before the pandemic, our team had been working on desensitizing our son to go into the doctor's office. And obviously there's been some regression with that since COVID. I'm wondering if you know, probably you don't know yet, but when that might be possible, because the more unsuccessful attempts or the more high anxiety attempts of going into a doctor's office, the worse it will be later. So curious about if you know any of that.
So we did start nurse tolerance back up. So all of the students that were working on tolerance programs, practicing in the nursing office to go to the doctor, working on blood pressure cuff otoscope, getting their heart rate checked, all of that, even dental stuff. We have a wonderful CNA who started after COVID to provide extra support, and she's taken on all of those programs, and she schedules out the kids multiple times a day at every location throughout the week. So that practice is now happening in the nursing office with the nurses and not at the desk anymore. After COVID, we had the teachers working on it at the desk because we didn't want to take too much time away from that practice. And now that the kids are walking around the building a little bit more, they're coming to the nursing office and getting a new face and seeing different equipment and, working on those things. And the next step will be going into the community if you need that support with the teachers. The difficult thing is just making sure the community is a safe place to be for our staff and our students, and getting into a car and all that kind of stuff is a little bit different than being in a classroom. So we have had multiple conversations about it. When we start opening up the community a bit more, it will definitely be one of the first things. If it is an emergent need and something that, a support is definitely needed as an emergency basis, definitely reach out to your clinical director, and they will reach out to myself or Lurie, and we'll kind of try to tag team to see what we can do to support the parent, because there are definitely situations where it does need to happen, and we'll be able to do the best that we can to get it safely done for you. Does that answer your question? Okay.
Quick question. I think this came up in the series of questions that I got in the last week for Dr. Bath, but regarding blood draws, real challenge for our kiddos and adults. And just wondering if we ever get to the point of where we wouldn't have to go to a lab with people that are unfamiliar with ASD, and again, unfamiliar people, period. Labs tend to be pretty stressful for our kids.
Oh, no question. No, that is absolutely on one of my top priorities, actually, is part of this whole service, is to be able to do the draws at the Lurie Center. There's a wonderful clinician there by the name of Jill Panetta, who this is what she specializes in. She specializes in kiddos and adults who struggle with these challenges around medical testing and blood draws and vaccines and things like that, to help do some desensitization, which it sounds like, Shelli, you guys are doing there as well. But we could take that handoff and do it on our end. And we have done this with some folks already, where we'll bring them in. We don't have any intention of actually doing the draw that day, but just to get them familiar on our side with the people and where they're going to sit and that type of thing. And and just to get them, and we'll do it when they're ready. And if that's a week from then, if it's a month from then, if it's 2 months from then, it'll be when it is. And then we just want to try to make it as comfortable as possible, with as much as desensitization as possible. We're not gonna, we really don't want to hold kids down and do these, draws, especially when they're bigger than us. And, so that is absolutely a priority, Una. So thanks for asking that question.
We definitely have had some successful trials with one of our older kiddos. I can reach out to the family and see where they went. I'm going to bet this is the Lurie Center, but they did start working on, and it can be, it doesn't really need to be anywhere, but we did a lot of nurse tolerance in the building. And then the parent or the staff at the time, and this was a couple of years ago, would take that individual to the blood draw clinic or the doctor's office and just sit there a couple times a week, and then bring them back and just sit there, and then introduce the equipment there. And it was a very long process, but if the Lurie Center does something similar, I can definitely coordinate with Dr. Bath and the family to see if there's a time that would be better for somebody to just come and sit and hang out in a unfamiliar environment. And we can build up to that for sure. We can just definitely work on more intense tolerance program, because it definitely has worked in the past, but I think this was done on a more individual basis and not necessarily included in NLG specifically, but it was successful.
And Justine, to add to the answer to your question is, I do feel strongly that, you know, if your child needs to be seen and really has an aversion to coming in, and, you know, we just can't get them there, I will do what it takes to make sure they get seen. And if that's at your house, that's at your house. If it's at NLG, it's at NLG. If it's in the car, in the parking lot, I'll do that. And so, because, you know, we don't, you know, I don't want to have any patient sort of go too long without having what they need. And sometimes it's just a matter of logistics, and, you know, we'll do whatever we got to do to make sure they get seen.
We have a question in the chat too. Will the Lurie Center be providing lists of CBT providers or mental health therapists to help with patients manage their anxiety, etc.?
Yeah, that's a list I'm gonna start working on as soon as I get there. You know, I'm gonna work with Julie and Ellen, who are the social workers who live there, get their resources. I have some of my own resources out in the community. So yes, that is absolutely a priority.
I just want to be mindful of our time. We've got about 5 minutes left until the hour. If there aren't any more questions, I don't know, Shelli, if you see anything.
We have one more.
Okay, great.
Just came in. I don't know if this is to the nursing office or the Lurie Center office. I assume the Lurie Center office. But do you do COVID testing in your office? Daughter's had 5 test 5 times, and it's been pretty easy because the pediatrician does it right in the office. Yeah, that's definitely to Lurie. And we do it at NLG too if you need it, but only on a symptomatic basis. But travel and stuff like that, exposures, I'm not sure if Dr. Bath has a.
Yeah, not yet. No, I wish we did. I'm not sure when we're going to, because I would have to get that set up from scratch when I get there. So, but no, there's no testing there yet.
And Una, that's it for the questions. Okay, great. I don't want to keep you too long. I know it's nighttime and almost bedtime for some of us, or trying to get to bedtime, but thank you both so much. I really appreciate your willingness to talk to everybody here, and I don't know if people know how to get in touch with you, Shelli, with additional questions. I don't know if Dr. Bath, you would be comfortable sharing information, contact information, or if there's a phone number or an email that you can pop into the chat so people can contact you with further questions if you're comfortable. And if not, I'm sure parents can call the Lurie Center to find out more about your schedule and your services. But thank you both so much for being here with us and taking the time to explain everything that you do to help our population. So thank you both so much.
Absolutely, it's been a pleasure. And I will, I'll get contact information to Shelli. And so, you know, if we send out anything post meeting, that can certainly be included. That'd be fine.
Great.
Yeah, when we send out the recording in the notes, I'll definitely include your email address.
Great, perfect.
Great. Thank you both.
All right, thank you, everybody.
Have a good night, everyone.
Thank you.
Take care.
Good night.
Night.